Good evening, everybody. Thank you for joining us on this winter's day. It gives me great pleasure to welcome you to tonight's topic. RSV prevention begins before birth. The importance of maternal vaccination and helpful consultation tips with expectant parents. So my name is Dr. Rodney Pearce. I'm a practicing general practitioner in Adelaide, and I'm currently the chair of the Immunisation Coalition. I am delighted to be chairing tonight's meeting. In the spirit of reconciliation, the Immunisation Coalition acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. We're here tonight for a multidisciplinary discussion. We've got a group to discuss the protection against RSV in newborn babies and infants up to 2 years of age through maternal vaccinations and or immunisation. And we're covering in particular the following areas, but a wide and diverse discussion I'm anticipating. So in particular, we're interested in understanding the burden of RSV in babies and in young infants, understand the role of maternal vaccination in helping prevent RSV after and from birth, to be clear when to recommend vaccinations and when to recommend immunisation against RSV, and provide some useful tips when discussing RSV vaccinations with patients either before or after delivery. So joining me tonight, we've got three healthcare professionals, but all from primary care, and they will be sharing their knowledge and experience of RSV in the clinical settings. So firstly, Dr. Srimal Nawana, an experienced GP working in metropolitan South Australia, strong interest in health promotion and preventive health, and has extensive experience with Aboriginal Torres Strait Islander health. Her broad experience has helped to adapt her practice to a spectrum of patients, including patients with optimal resources, but also those who have very limited access to healthcare. Welcome, Srimal.
Thank you, Rod.
Our next panellist is Sonia Elia. She works at Royal Children's Hospital Immunisation Service, and in 2017, she became Victoria's first nurse practitioner in the field of immunisation. She has a particular interest in vaccine hesitancy, special risk groups, needle phobia and immunisation education. She has received multiple awards, including the Dame Elizabeth Murdoch Nursing Development Scholarship and the Royal Children's Hospital Chairman's Medal. She's a teaching associate at Monash University and holds honorary positions with the University in Melbourne and the Murdoch Children's Research Institute. So welcome, Sonia.
Thank you, Rod.
And finally, Jenny True, a community pharmacist, 14 years based in inner metropolitan Walkerville in South Australia, regularly delivers immunisation under the National Immunisation Program, including maternal RSV, as well as influenza, whooping cough, and COVID-19 vaccines. Strong advocate for increasing vaccination rates and takes a proactive approach to integrate vaccination or vaccine conversations into everyday pharmacy interactions, particularly with expectant parents. So welcome, Jenny.
Thanks, Rod.
So tonight, to make sure that it's interactive and everyone gets a chance to comment and to feel part of it and to benefit from the experience of this amazing panel that we've got here, we ask people to put their questions on the chat line, and you can see them, anyone who wants to add them. We'll do our best to answer them. We also will put them specifically to panellists, but we do have the opportunity, because this is recorded, to actually follow up questions if we don't get an answer, or if you don't think we've provided a satisfactory answer tonight, which I find hard to believe. But if that's the case, because it's recorded and because we'll keep a record of it and we'll keep a record of your questions, we'll make sure everyone at least gets some answer and we can talk about it later. And none of this would have been available without the support of Pfizer for supporting us with their educational activity. So let's crack on. So I was just thinking, Shrimal, that as the cold hit South Australia, and I think the rest of the country is wondering which season it is, either floods, drought, or whatever, maybe talk a little bit about the clinical and the symptoms that a baby with RSV may have and some of the complications. But in the background setting that we've got over 61,000 laboratory confirmed cases this year, 50% or more are under 5, and a high percentage of those are under 2. So it sounds like we're on track for a record year. So as a practicing GP, how important do you think the RSV vaccination is going to be to protect our newborn babies?
So the availability of maternal vaccination is extremely important in protecting our community because, as you've mentioned, we've had an alarming rise in RSV with an average annual increase of cases of approximately 146% since 2021. So I think immunisation's our best strategy to control these escalating numbers. And maternal vaccination has been shown to reduce severe disease in approximately 70% of infants in the first 6 months of life when infants are most vulnerable. So I think, of course, there are all the universal precautions and other measures, but I think vaccination is really the key to preventing these escalating numbers from really overwhelming our health system. In terms of common symptoms are very similar to other respiratory viruses like influenza. So they might present with a fever, runny nose, cough, loss of appetite. In the more severe cases, they may present with wheeze, lethargy, shortness of breath, or even apneas. And in terms of complications, RSV is one of the leading causes of bronchiolitis, and it also can cause pneumonia. And another important complication is dehydration, because that often leads to hospitalisation because of the need for intravenous fluids. Oh, sorry.
The Abrezva has only recently been added to the National Immunisation Program. Now, it's a new vaccine. Are expectant mothers accepting this, or are they hesitant or undecided if they want to get vaccinated? And how do you manage it? And then I'll ask Sonia and Jenny, maybe in their context, a similar sort of thing.
Sure. So overall, what I've found is I haven't done the rural work yet, and I will be doing some in July, so I'll be able to get a better understanding then. But in metropolitan Adelaide, I've found patients are generally accepting, but we do still have a range of presentations. So in terms of approaching the range of responses, I like to basically ask very open questions at the outset. And I start with questions like, what have they heard about the vaccine? Do they have any concerns? And I like to also find out, do they have experiences with other vaccines which might affect how they feel? And if patients are accepting, obviously it's much more straightforward. I focus on the relative benefits and risks of the vaccine and possible side effects. And I then provide advice about optimal timing of the vaccine, and then provide or encourage them to have a vaccine plan. When we have hesitant or undecided parents, I take a different approach. So I carefully find out what the barriers are to vaccination. So I ask very specifically about their concerns about the vaccine and also other vaccines. And I like to find out what they've heard from family and friends and social media. So I'm able to work out what is stopping them from accepting the vaccine. And then I also really like to ask about what they know about RSV and the risks and problems of the disease, because what I find is quite often they have very limited knowledge about the disease. And of course, we have to be non-judgmental, use language that they find acceptable, and present facts that can help them with their decision making. I also find using numbers can be very helpful. So where there's hesitancy, I think giving them actual facts that they can understand in a simple way. So letting them know, for example, that 3% of children will have a hospitalisation before the age of 5 with RSV. So that can be quite powerful in helping them to make a decision. And I also like to talk about more general considerations which they might not have thought about in the process of vaccination. So, letting them know that, of course, it's very stressful to have a child in hospital with RSV, but it also has an impact on the parents' ability to go to work. It can have implications for siblings, such as needing to find alternate care for them, and also they might miss school or activities. So it has quite an impact on the family unit. And of course, children can develop further complications such as recurrent asthma and things like that, which leads to further sick days. So I think having a strong understanding about the disease and also the implications of contracting RSV rather than completely focusing just on the vaccine can be helpful.
Well, you've thrown down the gauntlet, lots of questions. So, Sonia, it's been talked about what happens in hospital. So I guess, interestingly enough, it's fairly new as far as a vaccine, but is the disease seen as new to people, or are they aware? And maybe, Jenny, you can comment afterwards. But Sonia, in hospitals, are the people you're seeing actually aware of RSV in the context as Shrimal's talked about?
Yeah, it's a good question. I'd like to say yes, but unfortunately they're not aware. So I actually just saw an infant today, a 5-month-old infant who was born in sort of December. So mum had not had the maternal vaccination. Now this infant had just been hospitalised with adenovirus, rhinovirus, and so you think that they would be aware of respiratory syncytial virus, but they actually had no idea. And so I talked to the family today about RSV and, really made them aware. And of course, for them, it was just having just recently been hospitalised with these other viruses. It was a very simple decision for them to proceed with immunisation. And, it just reaffirms to me that there's this real lack of awareness. But interestingly, as Strimmel said, when you talk about bronchiolitis, yes, families have heard of that. So while they hadn't heard of RSV specifically, they certainly had heard of bronchiolitis through, other family members whose children had been unwell. So I think when you do talk about the two interchangeably, there is a little bit more awareness of that.
And the disease that it can cause. So, Jenny, are you finding people come in having consulted Dr. Google or AI and decided they know everything about it?
I think people are more cognizant of RSV. They may not necessarily understand exactly what it is, but they know it's just another respiratory virus, along with rhinovirus, adenovirus, all those other respiratory viruses. And I think COVID did a lot of things for people's understanding of respiratory viruses as well. So they're coming in asking those sort of questions when they get the RAT tests, for example. Most of these RAT tests have not just COVID, but they've got influenza, and now they've added RSV to that. And I think I'm fortunate that I practice in a more of an affluent suburb that has a bit more health literacy. So I can only speak to my local community a little bit broader outside of that. And they're certainly in my practice, people are aware of what RSV is, and they're coming in asking the questions around vaccination, not just for expected mothers, but just in general. Yeah.
So I'll get to the question of having the vaccines together and what pregnant women are doing, but it's a new vaccine. It's just been introduced. People are used to 5 years or 4 years of COVID and all that sort of stuff. Do you think there's enough of public domain information? So I guess directing the question at whether the government's done the right thing, spent enough money telling people about RSV when they're just spending millions of dollars on this. So maybe, Shrimal, do you think there's enough in the public domain that the government's done?
I think it's very difficult because there are so many different competing health issues. It is hard to make sure each issue is dealt with. And I guess really we're coming towards winter, so we really want to get that message out before the peak. So I think more can be done for sure. And I think, I guess it would have been better if we'd had a slightly longer lead time, but certainly I think we need a little bit more public awareness.
Yeah, Western Australia had it, I think, before anyone. But Sonia, you're the expert on someone comes in. First of all, when they say, do I really, as a pregnant lady, need 3 injections at the same time? So maybe your comment, because I assume that your special interest in needle phobia is not a personal issue, but talking to patients about it. So your comments about 3 needles in one, the awareness of RSV as it's another vaccine, all that sort of stuff. So, Sonia?
Yeah, I mean, I think, early data suggests there's about 40% uptake of the maternal vaccine, which is obviously better than influenza, but there's still obviously 60% of, mums that aren't having the immunisation. And I think you're right. I think some of the concern is around another vaccine during pregnancy. But I think the important thing is really focusing on the infant. So this RSV immunisation is just as important as the whooping cough, immunisation in terms of protecting the infant. And I think once you explain that, and as Strimmel said, really explaining what RSV means for the infant, it's more around that. I think that parents or mums are really concerned. And I think there's also the fact that we're also running this, concurrent infant program, because of course some mums will sort of think, well, if my infant can get it, then what do I really need to have it? Especially because that is a new, immunisation. So it's a little bit more hesitancy around having an additional vaccine during pregnancy that essentially we could postpone and just, get the infant immunised instead, rather than sort of being concerned about, having 3 vaccines. It's more just, being immunised during pregnancies that seems to be the issue.
So technically, can you have 3 at once, and would you give it?
Yes.
Yeah, absolutely.
Unanimous shaking of heads here, because I'd be saying the same. So Jenny, your comments about, do I really need 3, or can't I just leave it for the baby to have them? And how do you bring that into the conversation when they're picking up their cough medicine?
I think co-administration is a huge thing. If we have that opportunistic ability to give them all 3 and reassure them that they can have that, it's not too overwhelming on the immune system, and there's no evidence that there is any harm or safety concerns in doing that. I think there was a bit of data around maybe it might have reduced the whooping cough, I think antibodies perhaps, but they weren't sure if that was clinically significant. So I wonder if anyone can shed light on that. But in terms of getting the immune response to RSV, though, that wasn't affected. So some mothers might, if they've read on social media or somewhere else, or someone's told them, hey, don't get it all together, it might affect your whooping cough. I have heard that, but yeah, if anyone can shed some light on that. But we certainly do a lot of co-administration, all 3 together, and haven't had any problems.
Strimmel, do you want to comment?
I think the simplest approach is really the path of least resistance. So if that is a concern for them, I think it's perfectly okay to get them to come back for the whooping cough vaccine.
Yeah, absolutely.
And then we've dealt with the issue and everyone's happy. So I think that's how I would approach that. And I think quite often if there's concern but they do want vaccination, more often than not they're happy to come back. So I think it's more trying to capture the people who are truly hesitant and won't come back. But I think those who want it but just don't want to have it together are more than happy to come back. So some people don't have their flu and COVID together, and I just go with what they're comfortable with.
Yeah, and some people say don't forget that COVID vaccines. I think the US has raised questions about COVID during pregnancy, but Australia still recommends them. So Sonia, in the hospitals, what are you saying to people? And it's been raised in the chat line. What is the recommended time? Because people say that there's been, I think, a few weeks change in the recommendations, but in my mind, it's fairly certain. So Sonia, what are you recommending, and what part of the pregnancy?
Yeah, so the maternal vaccine can be given from 28 weeks gestation. So the product information says 24 weeks, but the actual national recommendation is from 28 weeks. And there was some upper limit of saying 36 weeks, but there actually is no upper limit. So that's in the immunisation handbook, it's very clear that if a mother is at 36 weeks or 37 weeks and has not had the maternal vaccine, it can still be given as long as it's 2 weeks prior to delivery of the baby, to ensure that that placental transfer of antibodies occurs so that the infant is protected. It can really be given anywhere from 28 weeks onwards.
So Jenny, is that what you're telling people?
Yes. Yeah, you're following the national immunisation guidelines, which say from 28 weeks onwards. Yeah.
And you're finding the conversation is just with pregnant women who come in, or do you see?
Yeah, sometimes their partners may be picking up vitamins, iron supplements, antiemetics for their wife who is really unwell. So then we're able to opportunistically have that conversation around, have they had their maternal vaccinations yet? Did you know you could get them at pharmacy as well? And I think a lot of expected mothers don't realise that there is an opportunity to get them in the community now as well without an appointment. Being able to walk in some cases 7 days a week without an appointment just gives these parents a bit more flexibility to get these vaccinations without an appointment.
So, Srima, back in 2009, the first flu pandemic, swine pandemic, we didn't vaccinate many women with flu. Now we did flu. Then whooping cough was done, and there's your comments on how the whooping cough vaccine is now good uptake, and seems like everyone else who visits a baby in the first 6 months. So
Absolutely.
now we've got more. So what was the message you think that got the whooping cough in? And is that the same message you can use with this new one, or do you think it's a slightly different message?
Well, I think the main barrier is, I think since COVID, there has been a bit of a change in attitudes to vaccination. So I think when whooping cough was available, people were much more accepting overall. I mean, certainly our population here in Metro Adelaide is mostly accepting, but I think there are some misconceptions and things that are barriers with all vaccines. So I think with whooping cough, a lot of grandparents came in, and I think that's another factor that was helpful. So I think it's hard to know whether we'll have the same impact with pregnant women as with whooping cough because of those social changes that have happened. But hopefully, if we keep presenting the evidence, hopefully we can combat some of those misconceptions.
So when you say we, around on the panel today, we've got a pharmacist, a nurse and a GP, but we don't have a specialist. So is it our fault as primary healthcare physicians if someone doesn't get vaccinated, or is it the obstetrician's fault for letting them escape? So Sonia, do you want to tackle that, seeing as you're friends with lots of obstetricians at the public hospital? Well, you were until tonight, maybe. Yeah, go on.
I think everyone has a responsibility. I don't think it sits just with one specialty. I think we all have a role to play. So I certainly think that the obstetrician will be spending most of the time with the pregnant woman, but there's certainly opportunities for everybody else who's involved in the care of that person. I guess that's why you have a multidisciplinary panel to talk about our experiences, because we all are really having those conversations with pregnant women. So I don't think it really sits with one person. I think we all have a responsibility. And as Jenny has said, even if Dad's coming in to get medications, it's all of our jobs really to talk about RSV. And if uptake's not where we want it to be, then we're just not having enough of those conversations. And just to touch on what Srimal was saying, I think you can't also underestimate the power of social media. So I certainly think that uptake of whooping cough has been impacted, really by social media. And I think, as Srimal was saying, it's important to talk about the facts, absolutely, but sometimes it's about how people feel about the facts. So sometimes if you say that, 3% of infants can be hospitalised, with severe bronchiolitis, that may not be enough for someone. But when you actually talk about that one infant who was hospitalised with bronchiolitis and, what a devastating impact it had on the family, then sometimes that can really resonate with people as well. So I think it's important to have facts, but, also those anecdotal cases of the people or infants and, that we see with bronchiolitis or RSV.
Jenny, as the newcomer to the vaccination panelists, both for this meeting but also more recently being added to who can give vaccines under the National Immunisation Program, what's your thoughts on all of that?
I think pharmacists are really well placed in the community to help increase the conversation and the uptake of immunisations across the board, including maternal vaccinations. And it's about that ease of access as well. We're available quite 7 days a week, and sometimes we've got a few pharmacies now in Adelaide that are 24/7 as well. I'm not sure if they'll be vaccinating 24/7, but certainly those conversations can be had very easily in the community. So I think even though we're new, I think certainly pharmacists are very well placed, the ones that are trained and ready. We're already delivering all the other vaccinations and the maternal influenza and pertussis for a while. So RSV is just another important conversation to be had.
So the questions come up in the chat line. I'm keeping an eye on it and getting updates on my phone, so apologies for looking away. But who should get this vaccine? Is it every woman? One of the questions, and are people offering it to everyone? So Shrimal and then Sonia and Jenny.
Yeah, I'm offering it to all pregnant women, absolutely, who are in well, I sort of
Right,
mentioned.
yeah.
So yes, I do. I do offer it to everyone who's eligible, and I try to bring that conversation in early. So sometimes preconception, sometimes at the first diagnosis, so they're aware that it's available, and then plan it carefully closer to the time that they're actually due, and try to encourage them to have a plan, to have it relatively early towards that window. So because quite often they're juggling so many things towards delivery time, so it's ideal to have a buffer in case of premature delivery or in case other things crop up.
So Sonia, are you offering it to everyone and suggesting everyone has it?
Yeah, agree with Shrimal 100% that I think you can have the conversation much earlier, even though the vaccine is recommended from 28 weeks. You can certainly opportunistically have those conversations and make sure that the pregnant mum is fully aware. That way, you know, they make that plan to get the vaccine as soon as they're able, because I've certainly, you know, come across mums who, you know, then end up delivering their baby a week later. We've certainly seen that in practice. So yeah, it is important to try and get it as soon as you're eligible. So having those conversations early, but yeah, all pregnant women should be having that conversation.
So one of the questions that's been put to me, so if the mother misses the conversation, or maybe the mother says, and some of their feedback is saying that women would prefer to have the vaccine themselves rather than give it to their baby. But if a mother misses it, what's the kind of practical reality of a slightly unintegrated system in Australia and communication between hospitals and us? So maybe, Shrimal, you can start by saying, if it's missed, how's that being picked up, and what's sort of happening, and where's it being put, and where's the vaccine being given, you know, all that sort of stuff. How's that working in practice? Yeah.
Absolutely, it is very difficult because one of the factors is mothers and babies have different case notes when they, you know, once the baby's born, you have two sets of case notes. So, and the mother might have an appointment, or the baby might have an appointment. So sometimes you might not notice in general practice that the mother hasn't been vaccinated. So I think we have to explicitly ask the mum, were you vaccinated in that 2-week baby check or the 6-week baby check, or if they come in for some other reason, and also if the baby's a high-risk baby. So I think, I mean, because then they'll need to have it in any case. But I think, yeah, that is a bit of a tricky thing, and often they may not come in because other things are going on after the baby's born. So ideally, I think the conversation should happen while the mum's still in hospital. But if that doesn't happen, I think there's some of the opportunities we could use.
So Sonia, do you kind of make a note, or you think anyone in a hospital system is saying, oh, mother didn't have it, I better ring the GP, or is there a letter going out? Is that sort of part of the process that's happening now?
Yeah, so look, at the Children's Hospital, we're actually proactively looking at all of our inpatients who fit into the eligibility criteria for the nirsevimab. And we're actually then checking the Australian Immunisation Register for mum's maternal vaccination status to determine whether or not the infant is eligible. So you can sort of be proactive, but again, that's the Australian Immunisation Register is only as accurate as the people using it. So sometimes not all the maternal vaccinations are being recorded on the AIR. So as Shrimal said, it does rely on taking a history from the parents as well. And given that it is relatively new, I mean, I think mums are pretty clear about whether or not they've received the RSV immunisation during the pregnancy. They're very clear about, you know, their whooping cough and their flu as well. So I think it's a parent recall is quite reliable, but we're also using the AIR as well.
So Jenny, if someone approaches you and you're not sure whether they've been vaccinated, so there's two parts to this, and it's come up in the chat. Not so bad now because it's the flu season, it's the RSV season, so everyone should have it now, all that sort of stuff. So maybe when it's not part of the flu season or winter, how do you think you'll approach it, or what's your thoughts on it? And are you checking every newborn to see if mothers had the vaccines?
We don't vaccinate children, newborns, but certainly we have those conversations if they're coming in for any medications for the child, teething, Panadol, those sort of things, if they've had an immunisation at the GP. But certainly we don't see much of the recommendations of monoclonal antibodies in the community, but we certainly do just say to the parents that if for whatever reason they miss their appointment or are unable to get their RSV for whatever reason, that there is an injection that the infant can have if they get sick. And I think it all comes down to the language, but I try to keep it very simple, that there is an alternative that can still protect the child if for whatever reason they miss it.
So, Shrimal, I'm going to start with the question to you, but the fact that it's an injection but it's not actually a vaccine, vaccine hesitancy, not as a criticism, Jenny, but just to throw that in as a question, another challenge to us, because life's pretty simple and then it gets complicated by the day, and then someone in
try to simplify it so that they understand that there's an alternative. I try not to use the monoclonal antibody because it sounds a bit scary.
Well, that's what I was going to ask, Shrimal. Do you think, and then Sonia, your comments about with vaccine hesitancy, do you think there's an opportunity to perhaps start a conversation with people who are actually almost phobic of vaccines since COVID? Like we say, oh, here's a vaccine for us, and then suddenly it's like, no, this isn't a vaccine. So just your comments and your feelings about we're actually technically not got a vaccine, although I think in Spain it's called a vaccine, but nowhere in the world is a monoclonal antibody a vaccine. So, Shrimal?
Yes, I think language is very important, and especially for those who have misconceptions or fears around the word vaccine. So I think a good way is to say, so the same way that when we immunize a mother, the baby will receive antibodies through the placenta. We can also give the baby an injection that directly gives the baby antibodies that protects the baby from RSV. So using that sort of language to describe how it works, rather than using the word monoclonal antibody, which I think would certainly create fear, because then they go, what is a monoclonal antibody? And that sounds a bit scary. And I think just really sort of focusing on what it does, and really focusing on the antibodies being delivered to protect baby might be a more palatable way to receive that information.
Sonia?
Yeah, I love this question. So I think families are actually reassured by the fact that it's not a vaccine. So I'm always very clear that it's not a vaccine, but it is an immunisation. It provides immunity to the infant. And then I talk to the families about the fact that this is actually not really new. So we've been giving monoclonal antibody, palivizumab, for 20 years at the Children's Hospital. So every year we gave infants an injection every month over the winter months, and now we have this great product that is exactly the same. It's an antibody, so it actually provides instant protection. The immune system doesn't have to do anything. We're just literally going to give this baby antibodies to enable them to be protected for the whole 5 months of the RSV season. And because it's not a vaccine, we don't get a fever. We may just get a little bit of a sore leg after the immunisation. And families are really reassured by that. So I think, you can get to a point, particularly post-COVID, of being vaccine fatigue. So I think this is a really nice way to talk about it, that antibody immune system doesn't have to do anything. And I keep steering away from the fact that it's new, because, as I said, we've really been doing this for a long time. This is just a new version of the monoclonal antibody, in that it gives longer protection.
So, Jenny, do you like using monoclonal antibodies? Do you like using a new program? Where does it in your
I think I try to look at the mother and understand if she has a little bit of health literacy behind her, and if I'm able to avoid using jargon, it's always easier. But if they're receptive and they want to learn, then I'm open to using those words and explaining what they are. But I try to keep it as simple as possible, because sometimes when you start using long words, people tend to switch off, especially if they're don't have any health background or don't have much health literacy. Like I said, fortunately in my area, I do have a lot of health professionals as well. So they're already in the ecosystem, they understand. So I can only speak to my clientele in the area. But yes, I think using relatable language is always easier. I try to just say it's to help protect the baby, rather than using monoclonal antibody.
Shrimal, I'll get to you about maybe to the Indigenous Torres Strait Islander community, but Sonia, the language and some of the questions have alluded to this. It's passive vaccination or it's passive immunity. So we're giving, as you say, it's not new because we've had short-term monoclonal antibodies that we've used for probably a decade or so. And the trouble is you've got to give injections every month, wasn't it? Or every few months, I can't remember now. And so it was only really vulnerable children that we were giving it to, seen in the hospital sector, not in the community sector. So a longer lasting monoclonal antibody that can be given in the first year and the second year has revolutionised the protection for RSV that causes nasty disease. So Sonia, any comments? But I think that's where you were sort of coming about. It's not so new.
Yeah, correct, exactly. So in fact, last year we in Victoria were not receiving the nirsevimab, so we were all set to roll out palivizumab again, and again it was just high risk infants, but we were fortunate to get some doses from our interstate colleagues, and we were able actually to use nirsevimab last year for our special risk groups. And I think that's really important is that yes, RSV is bad for all infants, but particularly dangerous for those infants with special risk conditions. And in fact, I was talking to a family the other day. Unfortunately, their infant had received the Abrysvo. It was an error, so their infant did not get the nirsevimab. And so they had presented really to have a chat about the error that occurred. And I think in talking to them about nirsevimab, and they were really reassured by the fact that we had been doing RSV protection for many, many years at the Royal Children's Hospital, and that their infant would really benefit. And again, just because it is this first year of life, of course, if they're not medically at risk, it is just that first year. So I think some families seem to think that this is like flu vaccine. It's something we're going to have to do every year, but it really is. It's just this first year because they're most vulnerable. And so that family, felt really reassured by, that experience of having given monoclonal antibodies for quite some time.
Yeah. So Shrimel, talking about maybe a less literate audience and some maybe cultural differences. Would you like to comment on that?
So particularly Aboriginal and Torres Strait Islanders, is that what you were sort of wanting to?
Whichever you'd like to comment on.
Sure, yeah, I can talk about that. So I think doing vaccinations in that community, there are quite a few barriers. Firstly, I think in rural settings in general, we do have very significant issues with time and accessibility to healthcare. And so acute care is often prioritised by both patients and the health services. So I think resource limitations are a real problem in terms of providing care. And as a locum, when I'm there for a short time, I do have more opportunity and time to talk about preventive care with our patients there. So that does open up the opportunities. But another really important thing is developing trust. So quite often, if somebody comes that they're not familiar with, we really need to gain trust. So when I'm talking about vaccines and I sense there might be some hesitancy, I like to perhaps introduce that idea at a follow-up appointment with them. So I'll maybe order some blood tests and then follow them up, and then I'll start mentioning vaccination. Another thing that I might do is have discussions with health workers or clinic nurses, and sometimes if they're doing dressings or observations in tandem with my appointments, having that discussion as a group can make a really big difference. And quite often, that conversational approach helps to make them more comfortable and accepting of the message. Another thing that's very helpful is educating community elders and healthcare workers, because quite often the healthcare workers are members of that community, and then we have dissemination of information across the extended family. So even if I'm there for 2 weeks, having spoken to one person might then lead to other relatives coming back and asking more about it. So I think there are some extra things that we can do in that setting that does get us further impact. And then, of course, the usual things like health assessments and flu clinics we can also use to get the message across. So I think number one is resources. So I think it is good for these clinics to have additional doctors for a short period, not just covering their existing doctors, so that preventative care can be addressed.
So a couple of questions changed slightly, but similar. The vaccine that we're offering is to produce antibodies in the mother that the baby gets protection. So the reason 2 weeks before the delivery is talked about, because do it any later than that, the antibody protection. So that we had a question about can it be given, if it's given just before delivery, then the antibody protection isn't going to go to the baby, but there is some protection maybe through breastfeeding. And there was a question about breastfeeding and the difference between breastfeeding and non-breastfeeding, which I can't answer, but has anyone else got any answers? So maybe we need to look that up. And at this stage, it's only the first season we've been offering it. So the question is whether we should give it next year. Some of the data on the vaccine effectiveness is that it's more than 1 year, it might be even 3 years, but we recommend whooping cough every pregnancy because it's maximum protection. So I wouldn't be surprised if that's where we end, but that's new. Anyone else might want to comment. And the passive monoclonal antibody is lasting up to 12 months. So we anticipate it might be the first and second year for particularly vulnerable people, but I guess that's and it's different in each state. So just to make it complicated, so maybe we'll go around and ask everyone if they've heard of differences. I think South Australia is pretty easy, but some other states you've got to order it one at a time. So Sonia, do you want to comment, then Jenny, then Stream, about what's happening and the differences you've heard about?
Yeah, so there's really differences in the rollout of the infant program because, of course, the maternal program is national, so we're all doing the same thing. But the infant program is actually different in state to state. So in Victoria, for example, we are running a catch-up program for all infants born from the 1st of October 2024, where they can actually catch up if their maternal vaccination wasn't given. And that's for all infants. However, in New South Wales, it's actually different. So it's actually infants born from the 1st of October 2024 who are in a special risk category only. So healthy infants who have missed out will not be receiving the nirsevimab this year. New South Wales is also all year round. So, there'll be infants in New South Wales still receiving nirsevimab in December, but in Victoria, it's actually, it is just for the RSV season. So from the 30th of September, in Victoria, we won't be doing nirsevimab. So there are some differences, and actually the National Centre for Immunisation Research and Surveillance, NCIS, has a fantastic fact sheet that actually has state by state what each of the, because of course some families live on the border of, Victoria, South Australia, or Victoria, New South Wales. So it is available to families if they're unsure of what's happening in their state.
Yeah, so Jenny, there's restrictions and differences on pharmacy ability as well as the state differences. But again, I guess the principle is you're vaccinating the mother to partly protect them, but to get antibody levels so that the baby gets some benefit. And you're you're providing a monoclonal antibody to give 12 months protection. So giving it in October makes sense because it's going to take you through. So that's the logic, but whether the states and the Commonwealth help us deliver those things. So that's why we've got healthcare professionals at the coalface talking today, because we've got to live with what the bureaucrats don't do well. And part of the Immunisation Coalition's charter is to remind the bureaucrats they've got to make it easy for patients and for us. So Jenny, talk about some of the challenges with every state's different, not only for access, but every pharmacist has got different rules.
Yeah, so particularly for pharmacy and that catch-up program you were talking about, we don't have access to that. So there's not a lot of, information that we can provide other than referring them on to general practice, our colleagues. And then if they are going to hospitals for appointments, then obviously hospital with birthing services and paediatric services will have that catch-up program available. From federal to state, sometimes getting that information disseminated out into the community through really good health campaigns takes time. And like Shrimo said, sometimes you just need a bit more lead time to get that information out there. I think SA Health is doing a great job. I have seen some of their RSV material here in SA already in, I guess, non-clinical settings, so high traffic areas. It might be public bathrooms. We're seeing them in as well now, which is great because we want to capture education, not just in clinical settings, but just in high traffic ambient settings as well. So I think that's really important. But I think SA Health so far is doing a good job because I've seen that information out in the community, not just in my workplace or at hospitals. So that's good. But I'm not sure about other states and how that information gets out there.
And people on the chat line might want to make some comments, but I understand some states have to order them one at a time. So, but Shrima, did you want to comment on the differences and all the anomalies and all that sort of stuff, and how you're approaching some of that?
I think we're pretty lucky in South Australia because ordering isn't a problem so much, isn't it? So I think we don't have to worry about supply. But I guess if there is vaccine scarcity in other states, you have to plan much more about ordering and having very meticulous systems in place, I guess. And I guess you could do things like maybe have waiting lists or prioritizing those women who are closer to delivery. But I think we've been very lucky. We haven't had to worry too much because we've had quite good supply.
So I noticed a few people put up some websites, and I know that the Immunisation Coalition will make sure that we've got the NTRS material available after this, so that will be available. But let's get to the person who just says, no, not having it. They're full on no. And maybe we can start with Sonia. What's the approach you think, and I'll get Jenny and Shrima to just comment on how they approach it, almost refusal rather than hesitancy.
It's a tricky one. Look, I think it's interesting because I just had a special risk patient today that I was talking about immunisations, and they said, no, we're not having any. So it does come up, thankfully not daily. So I really think as a healthcare professional, our job is to inform, individuals, whether it's the parents, the person themselves being immunised. Our job is really to give information and give. So I always see my job as not being able to convince or persuade. It's really just to give the information, to give the facts and let them make an informed choice. If after that they're still making an informed choice not to immunise, I really have to respect their wishes. But really it just is giving the information. And as I said earlier, it's not just giving the facts, so talking about RSV, the disease, and what the implications are for the infant who's not protected, but also just bringing in those examples of infants that I've seen, admitted to intensive care with bronchiolitis. In fact, we recently had an infant who was admitted to intensive care with croup, which is really unusual to see, RSV causing such severe croup in an infant and being in intensive care. So if you can sort of bring in those examples, some people will say they're scare tactics, but it's actually just the realistic the nature of what we do. I always say I'm fortunate that I work in a hospital because I see what happens when infants aren't protected against RSV. And so to bring in the facts, but also bring in those anecdotal examples, but really give the information and let them make an informed choice.
Jenny, are you seeing many outright refusals, and do you have a sort of back pocket answer to that you pull out and trump everything? No, hang on, bad language. That you pull out and...
I think Sonia hit the nail on the head around giving all the information possible for them to make a decision. I think particularly if they're first-time mothers, they have a lot of questions, and I think that's completely understandable. So just taking that time to make them feel comfortable, give them opportunities to come back another time as well, because they want to take that information home, digest it. And you might not be able to get them back in the door the next time, but it could be the next time after that. So just giving them reassurance that we're here if, if and when they're ready, but it's also okay. It's also okay if they don't want to, that there's no judgment from us. They have their reasons and they have their right to refuse if they'd like. But yes, being able to build that rapport is really important. Again, I'm really lucky where I practice, we don't get many people outright refusing. But certainly they just have to be given an opportunity to go home and digest. Majority of the time, they will come back. It just takes a little bit more coaxing, and you can't win everybody, but you try your best.
Yeah, Shrima, did you want to talk about it and maybe comment on the literacy of some of the patients who you wonder about when they got refusal? But any comment overall about how to approach this?
I think, again, I agree. Very few patients are completely opposed and they're very firm on their decisions. And I think, as the others have mentioned, I do like Sonia's idea of bringing in those cases that she's seen, those families who perhaps have regretted not vaccinating or those sorts of things when they've had to deal with all the consequences, and really sort of elaborating like that can be helpful in making it real. But also I think, you know, our job is really to educate and provide information. I always say my job is to help you with your decision making, and the decision's yours, and I'm not here to make a decision, but to give you as much information as possible so that you can make the best decision for your family. So, and then I think the other thing is really trying to involve as many other health professionals in a subtle sort of way. So, because quite often we have slightly different approaches and something might resonate differently with another health professional. So I sometimes do also refer them to the Women's and Children's Pharmacy line. So where they have concerns about medications, we do have that service in business hours, and I find that's quite helpful because they can get some extra detail. So really trying to put in some different hooks for other people to help them, or perhaps, you know, it might be a good conversation to have at your next antenatal appointment, or sort of trying to bring in more people to give them those ideas. But ultimately it is their decision, and we can only provide information.
On the chat line, it's talked about, I think people are getting tired. What about providers? What about healthcare professionals? Sonia, do you want to comment on the fatigue maybe to the providers and the healthcare professionals?
Yeah, I'm not really sure, because I'm just so passionate about immunisation. I don't ever get fatigued. But yeah, look, I think in terms of some of the community providers, it probably is a bit overwhelming. Here's another vaccine, you know, immunisation that we need to talk about, you know, with parents. But I think that, you know, as I say, it's really our responsibility to talk about it. You know, as I say, it's not my job to, you know, convince them, and I'm not going to be happy if they don't walk out with a jab in their arm. It's really just, you know, you have a responsibility to tell the families about it. And really, because I've seen what happens when families end up with an error of omission, we call it, because essentially that child has ended up in hospital because somebody didn't have a conversation about that. And we've seen that with meningococcal, we've seen it with, you know, whooping cough. The parents get really angry when they're not told that they could have prevented this admission, they could have prevented this illness in hospital. So I think you just can't have fatigue. Like, I think you have a responsibility, and you don't want that ever to sit with you, that you saw a family and you didn't have that discussion, and then that child ended up with the illness. So even in families that I see on a daily basis, if I've got a 6-monther and they've come for 6-month immunisations, and we talk about influenza and they decide not to have it, I always document that they decline to have the influenza vaccine today, because I think it really is important that you have the conversation. It doesn't always have to result in, you know, the jab being given, but we just, the onus is on us to definitely have those conversations.
Jenny, you seen any pharmacy fatigue yet, or you think it's a different sort of world?
Not around maternal vaccinations, fortunately, but around COVID in particular. I know this is an RSV discussion, but I think that ship has really sailed, and it's almost a bit hard to bring them back unless they, again, from an emotive perspective, they know someone or are related to someone who's got a really bad case. So I think sometimes it is valid to bring in real life cases, because sometimes that emotive element does you know, give them a bit more perspective as well. And another thing with social media, I think Baby Riley back in 2015, 2016, I remember it, that did a lot for whooping cough. But I tell parents, we don't want another Baby Riley to be the reason why people take up something that's here, it's available. You know, I just think that that's the worst case scenario, where you've got a real life case. It's incredibly emotive. It's all over the news, all over social media, and then that finally kicks people into getting RSV vaccination. So I try to make parents feel a bit more cognizant that we don't want a repeat of the history, but sometimes, yeah, if they're still hesitant, we still try to validate their instincts, you know, that they're doing everything they can to protect their baby, and that this is just another tool in their arsenal on top of flu and, you know, whooping cough, which we do. So,
So, Shrimal, do you want to comment on maybe practitioner fatigue and/or your approach to that?
Well, I think it is a real challenge in general practice. As you know, we have quite heavy CPD loads and all those sorts of things. So I think morale can be affected sometimes, but I think it isn't an area that I think I think it's more the complex medicine that probably is fatiguing to general practitioners rather than the vaccination side of things. So I think most of us are probably not as fatigued on that front, but I think the workforce has been fatigued by all the different factors that have come into play. So certainly, yeah, we are dealing with a fatigued workforce.
We're getting towards the end of our time because we've almost done our hour. So, but someone's raised the question, Sonia, about is it a bigger responsibility of maternity hospitals and maybe the obstetricians to push this? And I know when I rang around to the private obstetricians, they said, well, that's your job to get the vaccine. So any comments on, is there a burden on the maternity hospitals to actually be more upfront and talk about this more, or do you think they're doing a good job?
Look, I do think there's room for improvement, certainly, and I think it really depends on what model of care that the pregnant woman is actually undergoing. So, of course, if it's shared care, then it's really, everybody's responsibility, both the GP and the obstetrician maternity hospital. But if it is, private obstetrician and most of their contact is with, the obstetrician, then definitely it sort of sits with them. And we're sort of hearing, a bit of a mixed response about, some obstetricians are really proactive and some are sort of like, oh, I don't think you need to worry about it, so we're sort of hearing both. But I think the actual professional law governing body for obstetricians is definitely proactive. And I think if we are encountering any issues with the message not being delivered, then we should certainly be referring, I think, to, that governing body around obstetricians. But I definitely am hearing from families, particularly at the Royal Women's Hospital in Melbourne, which is co-located with the Royal Children's, is that we're seeing parents coming down to the Children's Hospital to get the vaccinations because it's not being provided so proactively, at the maternity hospital. So I definitely think there's room for improvement.
Yeah, thank you. So we've only got a couple of minutes left, so 30 seconds for everyone to wrap up. So Sonia, you were just talking. Do you want to maybe do a final comment? Then I'll ask Jenny and then Srimal, and then we'll be able to thank everyone formally. So Sonia?
I guess just my final comment really on the nirsevimab specifically would just be around, reinforcing again that it's not really a new product, that we've really been doing this for quite some time. And, as I say, I see the devastating consequences of when infants aren't protected from RSV. And I think we all have a responsibility to talk about it throughout the whole, journey for parents, both, antenatally, postnatally, to really make sure that we maximise. I think this whole RSV program is going to be as successful as rotavirus vaccine in reducing the number of hospitalisations, ED presentations. We just have to get good uptake, and that's really going to rely on all of us.
Thank you. Jenny, a 30-second last minute comment.
I think just working really collaborative together as health professionals across multidisciplinaries to make sure that we're all having that cohesive approach around, I guess, maternal care, and that we're checking each other's blind spots. No judgment, just trying to capture those people for whatever reason they missed getting their vaccination, and able to capture them, whether it's in the GP setting or in the pharmacy setting or in hospital, that we're all sort of looking out for each other's blind sides.
Yeah, and Srimal, last comments?
Absolutely. I think the collaboration is very, very important, and really having all of us involved and helping to educate the community, because really one voice doesn't work. And also the focus on disease, because I've found personally that that is where a lot of patients don't realise that patients that's an area where I think we can persuade people better. So I think it's worked well for hesitancy with COVID vaccination by mentioning really how severe the disease is. We still have almost 5,000 deaths, those sorts of things. And I think, that has been helpful, but really collaboration and working together.
Thank you. Well, on that note, we've had a fantastic collaborative panel discussion. Thank you, everyone on the panel, for making yourself available. Real community difference, because people on the front line make a difference. Remember, this webinar is recorded. It's available through the Immunisation Coalition. We'll get up there in the next week. And we'll be sending a small survey so people can answer that online. And thank you to give us feedback to make sure we do it well, and your feedback on how to make it better for the community. Thank you, everyone. We really appreciate it, and thank you to our panel.
Thank you.
Thank you. Thank you.
Thanks.